Hello, friends. I'm Dr. David Brown, interventional cardiologist, founder of the Heart Hospital, and your host for Heart Talk, the podcast about everything heart. Today, we're excited and thrilled to be joined by Dr. Tim George and Dr. Aasim Afzal. Dr. George is a cardiothoracic surgeon who specializes in minimally invasive cardiac surgery and implantation of left ventricular assist devices for end-stage heart failure. He's also the surgical director of mechanical circulatory support at Baylor Scott & White Heart Hospital. Dr. Afzal is the medical director of mechanical circulatory services, easy for you to say, and ACGME program director for advanced heart failure and transplant at the Baylor Scott & White Heart Hospital. Please join us in welcoming Dr. Tim George and Dr. Aasim Afzal.
You're listening to Heart Talk with your host, Dr. David L. Brown. Dr. Brown is an interventional cardiologist, innovator, and co-founder of the Baylor Scott & White, the Heart Hospitals in Plano, Texas. He now serves as President Emeritus of the Heart Hospital's medical staff. And now, here's your host, Dr. David Brown.
So guys, welcome. Thanks for being here. I'm going to give a little introduction. We're going to talk about heart failure to our audience today. And this is one of the most rapidly increasing cardiovascular diseases in the country, right? And we're going to try to take a deep dive into it with a lot of things that move towards kind of the wheelhouse of both of you. Advanced heart failure, getting in the term heart recovery, heart failure recovery, the right term that you're going to develop for us, and moving on into even things including treatment, pharmacology, devices, Impella, ECMO, LVAD. But before we do that, we just want to get a little background. Let's tell the audience who you both are. So, Tim, let me start with you. And we've got the fortune to have a Midwestern guy with us. Tell us a little bit about where you're from and growing up.
Well, I grew up in northeastern Ohio, and I spent most of my childhood there. Went to college there at Case Western Reserve in Cleveland, and that's actually where I met my wife. My wife is from Texas, so there was a natural pull towards the South, and so we went to Georgia for medical school, and then I did some training on the East Coast at Hopkins and the University of Virginia. And then I interviewed for a job here in Plano, Texas.
And the CV was at UVA, right?
Correct.
Okay. And sports-wise, a little cross-country in college?
Yeah, a little cross-country.
Still running cross-country?
I still run, or I call it running. I think, if you saw me out there, you may debate what it was that I was actually doing, but I still consider it running, still like to get out there.
All right. But 3 kids, right?
3 daughters.
How old?
3 daughters. We've got 1 9th grader, 1 8th grader, and 1 6th grader.
And a big basketball family?
Big basketball family. So my wife played in college when I was running. I actually met her at one of her games. And all 3 of my daughters play basketball, love basketball. The most famous person in our household right now is Caitlin Clark. And so that's sort of where we are.
You've got a whole household of 22 jerseys?
Everywhere.
All right. We got to like that. And college-wise, you're still in the Mark Valentine queue of the Ohio State. Is that your team?
Yeah, well, it's hard, right? If you, especially in the 90s, you're in Ohio. Most of the professional sports teams are not doing well, and so you kind of gravitate to somebody who's successful, and that was the Ohio State Buckeyes. So we all grew up Ohio State Buckeye football, great. Michigan football, not great.
Well, I'm old enough. It's hard to leave the Cleveland Browns. I'm old enough to remember seeing Jim Brown on TV. It might have been black and white TV. I'm not even sure. But, it's hard to desert the Cleveland Browns.
Well, understandable. But there was a time when I was there, the Cleveland Browns had deserted us, and they had gone to Baltimore. So it was kind of a moving target.
That's fair. And so, Cowboy fan now.
Yes.
Favorite Cowboy quarterback of all time? Tough.
Yeah, tough. I mean, I mean, I really became a Cowboys fan by marriage. So I'm more of a modern Cowboys fan.
Okay.
So I've seen Tony Romo, I've seen Dak Prescott, and that's where we are.
Pick a favorite.
Well, Tony Romo was great. I'm still waiting for Dak Prescott to be great. I'm hoping he'd be great.
Hard to beat Tony. So talking about the Cowboys, Aasim, you've been here your whole life, grew up here. You got to be a Cowboy fan.
I am.
Okay, so
Diehard Cowboys fan.
all right. That's kind of tough sledding with the
For better or
general
worse.
manager. We may have to get enough money together to get one of you two to be the general manager. Could I offer you enough money to become the general manager of the Cowboys?
We have suggestions.
All right, so you've got to have a favorite Cowboy quarterback.
Yep. I would say Troy Aikman. I mean, that's my childhood days, just seeing him play and, America's team back in the day. But I know Tony Romo, George, and I think Dak still has potential.
So the
we'll
frightening thing about that, both of you, enjoying and sort of, getting to Texas as fast as you could, both of you Cowboys fan, America's team. I mean, the real quarterback is Roger Staubach. I can't believe that, we've got a whole generational miss here that you have no idea what you're talking about.
Well,
I mean, this is frightening in itself, right? All right,
I've seen those black and white videos. They seem really awesome.
It is a generational problem, no question about it. So, Aasim, I think we have another kid on the way, a baby due maybe Monday. Is that right?
That's correct.
Tell us about it. So,
Yeah. So
And your
I got a
kids.
baby boy coming. We're really excited. My 5 and 3-year-old. I have a 5-year-old girl and 3-year-old boy. They're probably even more excited than I am. They're just like hovering around the mama. And they've been making all these cards and things along those lines to welcome the baby boy. So super excited about the growing family, and and it's been good. It's been good. My wife is a physician as well. She works at UT Southwestern, and so we're both looking forward to it.
And basketball, your family?
Yeah. Well, I play basketball. I've been playing basketball since I was a kid. I'm not going to say I'm good at it, but I love playing it. Definitely a Mavs fan as well. Luka has been a breath of fresh air. Diehard Dirk Nowitzki fan. Watched the finals against the Heat. That was awesome. But yeah, so looking forward to the season coming up.
So that generates a great question for Tim. This is a question I asked Mark Valentine. Luka or LeBron?
Oh my goodness! It's so hard because at the time I was growing up,
He's going to have a stroke. We're going to have to put him on ECMO here in a minute.
No, but
Come on.
The time I was growing up in northeastern Ohio, LeBron was playing high school basketball, and it was televised more than the Cleveland Cavaliers.
Right.
But I would say Luka. I mean, again, I really follow women's Division I college basketball because of my girls. But as much as I watch the NBA, I'd have to say Luka.
He's just starting. So
LeBron?
Luka is.
Oh, all
Yeah,
right.
We'll see.
Okay. All right. So,
We'll see his
all right.
stats in
So,
5 weeks.
Given everything that you've both said in this little piece of basketball in 22, let me try it on both of you. Picking one of the three: LeBron, Luka, Caitlin.
I think you're first.
Who's your favorite? Pick one of those three.
I think they're in different parts of their career, but
Come on.
I'm biased. I'll pick Luka.
Okay.
I'm not a big basketball fan, although I met my wife at her basketball game and all 3 of my daughters play. And so for me, it's what my kids get excited about. And they get excited about Caitlin Clark, and I can't.
For me right now, it's Caitlin.
Yeah.
I mean, it's the world according to the WNBA.
Yeah.
Sold out seats in Indianapolis. Our heart hospital attorneys are from Indianapolis. I mean, now they're going to women's basketball games. How great is that?
Definitely
Listen,
changed the game.
Aasim, same thing. You're a Metroplex guy, right? DFW, born and raised.
Yeah, I grew up in Plano, Texas. Down the street from here, actually. Went to high school here at Plano Senior, and then decided to go to college here, actually, at UT Dallas.
So if you grew up here, did you ever drive by this block that the heart hospital's on?
I did. Used to be a golf course.
It sure was.
And I remember it's funny, when I was in high school, I remember driving down this street with my dad, and there was a heart hospital signboard on there on the corner of this parking lot, and it said future site for heart hospital, Baylor Scott and White. And my dad knew I was interested in cardiology, so he's like, hey, maybe you'll get to work in this place one day. And well,
And so that's when you were 12?
that was when I was 12. That's right. Yes.
Okay. And there is an interesting story, if you're willing to share it with us, about why you got into medicine. You know, how we got into medicine.
Yeah. So yeah, I share this story actually partially because it's really true and true to form in terms of why I went into medicine and what my passion is. When I was 8, my middle sister, who was 12 years at that time, got diagnosed with lupus. And she ended up having a pretty rough course over a 3-year time period with systemic lupus, a lot of time at the hospital with hemolytic anemia, multi-system organ failure, recurrent transfusions. And my parents both were very heavily involved with her care. And I spent a lot of my time during that 3 years at the hospital, sitting in the waiting rooms, begging the nurses to let me go see my sister. And well, 3 years later, unfortunately, she passed away. But both myself and my older sister, we ended up in a career in medicine because I think it just kind of gravitated us towards going into medicine and taking care of people. So,
well, both of you wound up obviously in cardiovascular disease, but I'm going to say as we've grown from an era when I started in cardiology, there were no subspecialties in cardiology, to now there are 9.
Yeah.
And to me, you two have picked and narrowed yourself into the most time intensive of all of them. I mean, we can talk about all sorts of other parts and pieces of cardiovascular disease, but there's an element here to me that kind of gets into the neurosurgery mentality whenever those guys go and operate for 12 hours. The intensity of these patients, especially as we get to the end, is really what we want to talk about a little bit about today. So, Aasim, how about starting us off with some definitions? Let's go through some definitions, maybe starting as simple as heart failure and working through heart failure, advanced heart failure, one of your favorite words, recovery, and let's play off that and then see what Tim has to add to this.
Yeah. So, heart failure obviously has a huge morbidity burden and a cost burden as well, right? So 18%, 20% of our readmissions are from heart failure, and nationally, $6 billion in healthcare cost nationally on a yearly basis. Multi-million individuals across the country as well as the world are dealing with heart failure. Heart failure is an all-encompassing term because you can have patients who have normal heart ejection fraction but have diastolic dysfunction, and then you have patients with severe systolic heart failure as well. So, it's kind of a spectrum from taking care of those patients that have mild diastolic dysfunction requiring a touch of diuretics to taking care of these advanced heart failure patients who are refractory to all therapy, in shock, needing advanced therapies like transplant and LVAD. And so as a heart failure specialist, we take care of all facets of heart failure. And the field has truly evolved over the last several years, I would say in the last decade, to even getting more subspecialized. So we have developed into amyloidosis and hypertrophic cardiomyopathy and genetics and hypertrophic cardiomyopathy, congenital diseases, or HFpEF dyspnea clinics. So a lot of subspecialties have kind of evolved from the heart failure specialty itself. But, ultimately as heart failure doctors, and I get to hear this from patients all the time, that why don't you guys call yourself heart recovery doctors? And I think that's true, because what we are trying to do is to get patients to avoid being an advanced therapy candidate, try to get their clinical picture better to a point that they're truly in remission from heart failure or have recovered from their heart failure. And that's pretty much central to what we do as heart failure specialists on a day-to-day basis.
How well have we renamed things? How well have we renamed the team? How well have we renamed the clinic? in terms of recovery?
So, nationally, we talk about this at every conference, whether we go to HFSA or ICHLT, we always have this conversation. We should rename our field. Why do we have failure in our field? But, that obviously takes a lot of momentum. But locally at our hospital, one of our previous heart failure transplant fellows actually did a quality improvement project. And what we did was we actually gave a simple survey to the patients coming to our heart failure clinic to say, hey, what are your perceptions of coming to a heart failure clinic? How would you feel if the clinic was named differently, if the team was named differently? And we got an overwhelmingly positive response on saying, hey, if the team was called the heart recovery team, or if I was coming to a heart recovery clinic, I would feel a lot better and a lot more optimistic about the trajectory of my care and what the outlook is for me. And with that in mind, we ended up changing the name for our center to the Heart Recovery Center. We call our team the Heart Recovery Team. And honestly, the patients, they really appreciate that. I get comments about that on a daily basis that they're like, hey, I feel so much better coming to a team that has recovery in mind, because we know that we're looking out for getting them better.
I think that's been fascinating. I've loved the whole team movement of that's recovery, and I think it's been a good thing for the whole team to do that. Tim, instead of letting everybody go linear, I'm going to jump the shark a little bit, go to the back end. He used the word LVAD. So in definitions, I'm going to ask you to work us backwards, perhaps, by telling us what LVAD is, maybe jumping back to ECMO, what it is. And even though Impella is a word, not an acronym, walk your way back, LVAD, ECMO, Impella, and just walk us back through that with some definitions and understanding.
Sure. So LVAD, first of all, stands for left ventricular assist device. And what it is it's a durable, or you could say permanent pump that we put in the heart to push blood forward. And so when we think about heart failure, just like Dr. Afzal said, heart failure it's a difficult word, right? Because if you have a blockage in your heart and you have chest pain, you have heart failure. And if we do bypass surgery, you're treating heart failure. If you have a leaky valve and you're short of breath, you have heart failure. And if we fix the valve, we're treating heart failure. When we talk about advanced heart failure or end-stage heart failure or people who need LVADs, what we're talking about is the people who've already had all that. They had the bypass surgery, they had the stent, they had their valve fixed, and they've been on medicine for a long time, and now that's not working, and they still feel short of breath. They still feel tired, and those options are not effective anymore. And so generally we're talking about people who have decreased heart function, which we measure clinically with left ventricular ejection fraction, and we're talking about people who have an ejection fraction less than 25%. They were on medicine that was effective, and it's not effective anymore, and they're not able to do what they want to do. And it's at that point where not only are they limited in what they can do, but the heart failure has become a threat to their life. And so that's when we start thinking about, do we need to put in a durable pump that will get better blood forward so that they can do things, but also get more blood forward so it'll save their lives.
A little rapid fire for both of you. I thought about buying 2 buzzers for you each to hit and see who got it first. But without the buzzers, either one of you answer and just see if you can fill in some blanks here. And some of this we may not know. But how many transplants are done in the country?
About 4,400.
Okay. And how many are done in the state of Texas? We know?
I think right about 250.
Okay. And locally for the Metroplex, how many have you got transplant-wise?
Right around 130 or so.
Oh, 130.
Yeah.
Okay. Can we try the same thing for LVAD? How many LVADs are done in the country?
About 2,500.
Yeah.
How many programs are in the country that do transplant? Changed on you here.
Yeah.
Okay. You got to be fast. We're moving. How many programs do transplant?
It's about 90 programs.
Okay. How many programs do LVAD without transplant? Tricky question.
Yeah.
I think there's about 100 or so.
That's what I was going to say.
Okay.
Centers,
Yeah.
All right. So I thought maybe it was a sub 100, but sounds.
I'll
better.
correct it. So it's about 180 transplant centers, and then probably another 100 out of that, about 100 LVAD centers or so. Yeah.
Okay.
So about 250, 260.
All right. And we don't do transplant. And so who does more LVADs that don't do transplant than any other place in the country?
Recently it's been us.
Okay.
Recently we've had the largest non-transplant LVAD program. Sometimes we call that a destination therapy LVAD program, by which we mean, LVADs historically were sometimes put in people who were not candidates for transplant, and we call that destination therapy because it's the final therapy that they're going to get. But they also were put in people who were waiting for transplants, and we used to call that bridge to transplant as a designation. There are also patients that are implanted as bridge to decision, meaning we're not really sure where we're going, but we need to do something now. And so, this program has grown very rapidly from a small program to one of the largest, if not the largest, non-transplant LVAD centers.
And you used the term was, Tim, but don't we still use the terms? I mean, isn't it fundamentally still?
No, you're right. You're right.
Decision and destination therapy.
No, you're right. What's happened, and Dr. Afzal can speak more to this, is the way that they've changed how transplant has really decreased the bridge to transplant cohort. So even though the terminology is still there, I think it's a mixture of more hearts being available has decreased the bridge to transplant therapy, but we also have safer and more stable methods of supporting patients who are waiting for hearts but are sick. And that will come back, maybe we'll talk about Impella and ECMO later, but we have these temporary pumps that they used to be very dangerous to put in a temporary pump, and you'd have to go and you'd do a sternotomy and you'd go on cardiopulmonary bypass and you'd put in all these complex tubes, and there was tremendous bleeding and people were on the ventilator, people were on dialysis. And so it was very dangerous to put people on temporary pumps. And now these pumps can be put in through really minimally invasive surgeries, and you can support people for 4 weeks, 6 weeks, 8 weeks while they're waiting for a heart. And so that cohort has shrunk. Would you agree with
I agree. I mean, I think, and it's important to put these numbers in perspective, because if you look at about a decade ago, we were doing about 3,200 transplants a year nationally. And that number had been consistent for almost 2 decades prior to that. And we have been able to go to the next evolution of transplantation, which with hepatitis C donors, partly, unfortunately, because of the drug pandemic, and also because of the ability to do DCD hearts, which is donation after cardiac death. And all those aspects have increased the volume of transplant. And what has happened is that we had a status change listing in 2018, which led to a difference in terms of how long patients will have to wait when they're really sick on ECMO or Impellas, and it prioritized those patients to get transplant faster. And so that helped us get patients to transplant when they're really sick instead of going to an LVAD. So we saw this gradual decline on these patients who were getting an LVAD as a bridge to transplant. And so patients who are not candidate for transplants are the ones who are getting destination therapy LVADs at this point. And so the bridge to transplant cohort used to be about 30% of the LVAD volume, and is now down to about 2%.
Which is a great story. So what do either of you see for the future? There's been this 30 to 35% jump, if you will, because of the things you touched on. What does the next 5 or 10 years look like? Do we have any change in the mentality?
Yeah, I mean, I think there's 2 parts to that. So one part is, and I think I feel more comfortable talking about this part, and I think he'll talk about the other part, is there's still a large population of people who could benefit from one of these therapies that is getting neither. And so if you say there are, let's say 4,500 heart transplants a year, and let's say 2,500 LVADs a year, we estimate, and it's always hard when you make these guesses, but we estimate there might be between 15 and 20,000 people a year who could benefit from these therapies. And what that means is actually the majority of people who could benefit from an LVAD or who could benefit from a transplant are getting neither. And unfortunately, that means that they're dying before they need to. And so I think the future of this will involve, one, is tapping into that population. We don't totally understand exactly why we don't capture everybody. Some of it is the nature of the deficiencies in the healthcare system. Some of it is limitations of LVAD. One of the things LVAD, and we can talk in more detail, LVAD has become a tremendous technology. It went from a large, clunky technology in which you had to be in the hospital with an LVAD and you couldn't move around very much to a small device. You can hold it in your hand now. It's fully implantable, but it requires too much power to be completely implanted. And so there's a power cord. We call it a drive line, but it's just a power cord that we tunnel out of the skin and we hook up to battery packs that you carry with you. And the batteries are great. They can last up to 18 hours. So you can go to school, you can go to work, you can go to church, you can go shopping, you can do sports. But you always have to bring batteries with you. You always have to recharge your batteries. You can't fully submerge your body in water. And for a lot of people, they go, I don't want that. And so there's certainly a component of the population that just says, I don't want that. That's an area that we can improve. And as we talk about what's the future of LVAD technology, the future is some kind of transcutaneous energy transfer where everything is inside and people can do everything that they want to do. And that technology is coming, but I don't know how quick it's coming.
All right. So, Tim, we talked a little bit about survival rates. Touch on
Sure.
that real quick.
So, to put it in some perspective, if you talk about people who need LVADs and don't get them, the best data we have would suggest that on average, those people will live 6 more months. Now, that can be misleading. You know, the person who comes into the hospital, they're really, really sick. We put a temporary device in them. We essentially have to do an LVAD or turn off the device. Their life expectancy is hours or days. But if you talk about somebody who comes in, they're not doing well, maybe they're in the clinic, maybe they come into the hospital, but they can go home. Those people, they can go home and they'll feel better for a while. And we usually will put them on inotropes. We'll put them on medicines that make their heart squeeze better, but they feel better, but they don't live longer. And on average, that person will live 6 more months. Now, if we do the LVAD, of course, just like any big operation, is particularly on a sick person, there's an operative risk. And that operative risk is somewhere between 5 and 8% mortality at the time of surgery. And when we talk about operative mortality, we're not usually talking about dying during surgery. We're talking about within that first hospitalization of surgery. But then what you're looking at is very close to 90% 1-year survival, probably mid 80% 2-year survival. And you're talking about more than 50% of people living 5 years. And again, it's all about context. You say, well, 5 years doesn't sound like a lot, but compared to 6 months, it's a significant improvement.
Well, and without being too specific, you're talking about people who may have an ejection fraction of 10 to 20%.
Correct.
Maybe 8, maybe 19. So let me shift gears for a second. You said a couple of things I want to come back to, but Aasim, let's talk about one of your and my favorite subjects, cardiogenic shock, as a jumping off point to lead us back to where we were going there. So take that as a jumping off point.
Yeah, so cardiogenic shock, I mean, as Dr. George was kind of alluding to, is when patients are coming in really, really sick, they have low blood pressure, they have end organ perfusion damage, and you're seeing a low cardiac output with hypotension and volume overload. We see that happen because they have a bad heart attack, and that's leading to cardiogenic shock. We can see it in setting of decompensation of their chronic heart failure, which is a lot of the heart failure patients that we see in the clinic. It can happen from myriad of causes. Sometimes it's a combined distributive and a cardiogenic shock. It's a setting of sepsis leading to cardiogenic shock as well. So there's several different facets of it. When we take care of patients who are really sick and in shock, coming on multiple pressors and inotropes, we work on those as a team. And so we have a shock team where the heart failure transplant doctors, as well as the CT surgeons, the interventionalists, the critical care doctors, the hospitalists, and the palliative care doctors, we all work together on taking care of these patients because it is complex, it's hard to diagnose, it's hard to manage, and getting all the heads together is how you manage these patients. And typically, the way it has evolved across the country is that you will have these tertiary level centers that have all these devices, such as the Impella and the ECMO that we discussed, and options for advanced therapies such as LVAD and transplant, managing these really sick cardiogenic shock patients with relationship with these other centers that don't have all of those facilities and resources on site. And so if a patient presents to one of the smaller facilities, they get transferred into a tertiary care or a quaternary care facility like ours and get managed over here. So we work very closely with our sister hospitals and referring facilities to take care of these patients.
Okay, so let's go 1-2 for a second. We've talked about LVAD a little bit. I'm going to start with you and ask you to talk about, where that cardiogenic shock patient might wander to get past the drug, and maybe you start with Impella, and then after that, I'm going to get you to go to ECMO for a second. Okay.
Yeah, so let's say you have a patient that came in who's pretty sick, they're in decompensated heart failure, or you're on a couple of pressors, and what you start noticing is that their kidneys are not responding to it, or you can't keep their blood pressure up, and you're having to go up on the drips and going on escalating pressors and inotropes. That's when our team, the shock team, will sit together and be like, hey, what's the next iteration of management for this patient would be? And so that's where the conversation about temporary support devices comes in. I know Dr. George kind of touched base on what the durable LVAD is, but what temporary devices are kind of similar mindset where you're taking blood from the heart and pumping it to the rest of the body. And
just describe the Impella a little bit.
Yeah, so Impella is a microaxial flow pump device that takes blood from the LV cavity and puts it out into the aorta. There's several different types. So there's one that is an axillary Impella, which is a 5-liter Impella, or called Impella 5.5, where it takes about 5 liters of blood from the heart and puts it to the body. So it's a bigger cannula, bigger framework. The CP Impella, we typically will put it from the groin. You can put it through the axillary as well. And that provides about 3.5 liters of blood flow. So just keep in mind, an average body habitus would require about 6 liters of cardiac output. So these devices are assist devices. They're providing cardiac output enough to kind of sustain life. And what we have noticed with Impella devices would be that we see resolution of an organ damage. So we start seeing their kidneys get better. We see their liver numbers get better. We see their come down on pressors and get them to diurese and hopefully reverse the cascade of cardiogenic shock that they were in. And then at that point, either they're going to go down the recovery pathway where we're able to get the device off by weaning it slowly back to kind of getting the patient ambulatory, getting them on guideline therapy. Or if they're not weanable because they're still very dependent on the pump because their heart is really weak, that's when we start talking about advanced therapies.
So for our audience, what's the longest you can stay on an Impella?
So that's a tricky question because technically, most of the times we will keep the patients on an Impella device for about 7 days or so. What's the longest? We have done it for about 38 days with the 5.5 Impella. Now, the bigger Impella is a little more hemocompatible. It's axillary, so patients can walk around. It doesn't cause as much hemolysis or sharing of the blood cells. So it works a lot better in terms of hemodynamic profile. So those pumps, we can keep them in for a little bit longer. So you see that in transplant patients or patients going to an LVAD that we keep it on for a little bit longer.
And the point of that was, the short answer is, this is something for days, maybe weeks.
That's correct.
We get past a month, we got to do something different, right?
That's right.
Tim, you want to talk about ECMO now? Tell us what
sure.
ECMO stands for and what we got.
Sure. So ECMO stands for extracorporeal membrane oxygenation, which is why we most frequently just call it ECMO. I think the easiest way to think about it, although there are some differences, the easiest way to think about it is it's cardiopulmonary bypass, or the heart-lung machine outside of the operating room. And when we do heart surgery, the cardiopulmonary bypass, we might be on bypass for an hour, we might be on bypass for a couple hours, depending on the complexity of the operation. So that circuit is designed for that duration. The ECMO circuit is designed for days, maybe weeks, but really days. And so it's a slightly different circuit. It works slightly different. But what a patient would see, or a patient family member would see, is you have one tube going in through a vein in the body, usually the femoral vein, but it could be any vein going into the heart to drain blood out of the heart. And then you have one tube going into an artery. It's most commonly the femoral artery, but it could be another artery. And the blood in between, it goes into a pump. The oxygenator puts oxygen in, it takes carbon dioxide out, and then it returns the blood to the patient. And so it does all of the pumping function that the heart does, and then it does all the gas exchange function that the lung does. And so we consider it full cardiopulmonary support for the patient.
Um, if you will, talk a little bit about what COVID changed for ECMO just a moment.
Yeah, I think so. COVID is so ECMO has two different main modalities. One is what I was describing before. We call that veno-arterial or VA ECMO, and there we're supporting the heart for sure, and often the lungs to some degree, and you can give full cardiopulmonary support. In COVID, people had, by and large, not only, but I would say in most cases, they had respiratory failure and when they became refractory to conventional mechanical ventilation, being on a ventilator or a respirator, we would consider putting them on ECMO. Now, that was a little bit different, and we call that veno-venous or VV ECMO. And the reason we make that distinction is we're mostly using the oxygenator and not the pump. So we would put a tube in the vein to drain blood into the pump so that we could put oxygen in and take carbon dioxide out. And then we put another tube again into a vein to return this well-oxygenated blood to the patient. And actually their heart would still push the blood forward. We were just doing the gas exchange with the oxygenator. And what that allowed in COVID was we could, the ventilator's great. The ventilator will support you when you can't breathe. If your lungs get really, really bad, the ventilator starts to hurt you. And the more you use the ventilator, the more it hurts your lungs. And so we would put people on ECMO, and then we could turn the ventilator down so their lungs could rest and recover. The biggest difference is those patients unfortunately need ECMO for months. And we had patients that went 9, 10, 11 months on ECMO and recovered, but it really just took that long. And so what that changed for us, and I would say many centers in the country, was they got a lot of experience taking care of these patients for a long time. And what it prompted us to do and really encouraged us to do was to wake these patients up, to get these patients walking, to get them moving around so that they're not just sitting there in bed, losing muscle mass and deteriorating.
And on that note, one or both of you talk just a little bit about the nursing staff and what evolved as a result of that in COVID and the length of runs and all this stuff. Talk about the nursing staff.
I would say what we did in COVID, I was so tremendously impressed with the nursing staff, because what had historically happened is, we would have a patient, they have respiratory failure, they get intubated, they go on the ventilator. We can't support them on the ventilator, so we paralyze them. So now they're sedated, they're paralyzed, they're on the ventilator. Now we still can't support them, so we put them on ECMO. And the knee-jerk reaction was keep them sedated, keep them paralyzed, they don't move, and see how quickly the lungs recover. And if the lungs are going to recover in 2 or 3 days, that's probably a workable thing to do. But in these cases, they were not. And we were going 3 weeks and there was no sign of recovery. 4 weeks was no sign of recovery. And actually what we were seeing is the lung volumes were getting smaller and smaller and smaller. So the disease process was still ongoing 2, 3, 4 weeks in. And so we were looking at, we're going to be a month, 2 months, 3 months. And so keeping somebody paralyzed and sedated for that time, they're unlikely to recover. Even if their lungs get better, they are not going to make a recovery. So, midway through, or I wouldn't say midway, but on the early part of the pandemic, we could see this wasn't working. And so, as a team, we talked to the nursing staff and I said, look, I'm going to ask you, can we wake these patients up? Can we get them up and walk? And imagine, this is the sickest patient in the hospital. They're on a ventilator, they're on a bunch of drips, they might be on dialysis. They've got a machine outside their body that's circulating their entire blood volume 2 or 3 times per minute. And you want me to walk them? And they said, if it'll help the patients, we'll do it. It was amazing.
Anything to add?
No, I mean that's what I would say. I mean, COVID was challenging times for everybody in the healthcare field. And the nurses rose to the occasion.
It was an extraordinary time for our hospital,
it was.
Our nurses, and what they brought to the front line.
Yeah, exactly. And the nurses, just the camaraderie amongst them and the goodwill of coming and doing extra shifts and taking care of these really sick patients, staying after hours. And communicating with us. And it wasn't easy to have all the isolation precautions and taking care of these really sick patients day in, day out. I remember seeing nurses coming out of the room and their whole face had like the mask lines all throughout. I mean, it was impressive. I mean, that degree of dedication, salute to those
Effectively,
nurses.
this was a combat zone. I mean, all
It
across
was.
the country, and this was a mass unit as we go through that.
Yeah.
Well, and to that point, in many ways, this is not what we do, right? We are a heart hospital. We do cardiovascular service line, and we had done respiratory or VV ECMO here and there because there was a need, and in this case, there was a tremendous community need, and the hospital was extremely supportive. We pared down what we were doing in terms of elective heart surgery to take care of COVID patients because we had a capability in ECMO that very few centers have. I couldn't tell you exactly how many centers have it, but in the Metroplex there are 4 centers that can provide ECMO, and there are hundreds of hospitals probably. So
yeah, no, it was a moment of time that never be forgotten. So we've concentrated, I'm going to say, a little bit on inpatient, on cardiogenic shock, on cigarette patients. Let me move to outpatient for a moment, to heart failure clinic, heart recovery clinic, whatever we want to call the clinic. Aasim, talk about that. People who can walk into a clinic, people who can be seen as an outpatient as opposed to our emergency transfer mentality, and just talk about that piece as well as the growth of that.
Yeah, absolutely. So, our heart recovery center, our mentality has been very straightforward, which is any patient who has heart failure, they are looking for an opinion from us, or a cardiologist who has a difficult scenario clinical scenario they're dealing with. They can use us as a second opinion, or they can have the help from us for managing these heart failure patients. And what we have developed is a kind of a overall treatment strategy as a one-stop scenario where you come here, we're going to make sure we figure out the problem and address the problem. So we have the CV line that is very truly integrated with the heart failure clinic. We have the valve team, the structural team, the EP team, and we work very closely together to take care of these patients. Our goal is not to be hospital-centric. Our goal is to be clinical-centric. And that's what we did when we started our program. And fortunately, the growth has been tremendous. Patients saw the need. We saw the need in our area. We're the largest heart failure clinic in the county. And we have almost 5,000 heart failure patients that we're taking care of. And from that, it evolved into taking care of these subspecialties that I had mentioned earlier of patients with amyloidosis and patients with sarcoidosis and patients with hypertrophic obstructive cardiomyopathy. And the field has rapidly evolved. And what I've noticed over the last 4 years, more so than the last 2 decades, of new drugs coming to the market, new updates to the guideline therapy, new updates to guidelines from ACC for heart failure management, for amyloid management, for HCM management. And so field has rapidly evolved, not just in terms of medications, but also from therapies, from options like devices that can potentially help manage heart failure symptoms better. And so our clinic has the ability to provide all of those services to the patients with a dedicated area for giving IV infusions to patients who need infusions, IV diuretics to patients who need IV diuretics. We have dedicated heart failure certified nurses that are managing these patients with us. And so there is a easy accessibility. So if a patient is at our clinic and they have a question about weight gain or about salt intake or about anything about their medications, they have a direct line to a heart failure nurse that they can call and get help. And that has really helped us keep the patients outside of the hospital. And what we noticed is that our heart failure readmissions went tremendously down for the hospital. I mean, we are at 6% readmission rate for the hospital from our clinic, which compared to the national average of 21% is impressive.
Stunning.
So, and that's been the mindset for our clinic. And we're very proud of what we have built. And we've fortunately had to move the clinic because of the growth about 3 times into bigger spaces. And we're about to move again, but that's great.
Well, that's the point I was going to make next is, in 21st century healthcare, oftentimes it may be somebody telling you a 6-month wait to see a certain physician or a certain doctor. If I have a sibling or a spouse, a kid or a father or mother How long does it take to get them into our heart failure clinic?
Our goal has been 2 weeks. That's kind of the standard that we're trying to set. These patients are sick, and if they need help, we want to get them in as quickly as possible. And that's why we've been hiring physicians as well as nurse practitioners to keep with that goal. Fortunately, the growth has been tremendous. So as long as we can kind of keep that metric in place for us, we will keep on increasing our team.
Historically, as we've spread out this over multiple subspecialties of cardiovascular disease, we've typically had those individual clinics 1 day a week or a half day a week. How often do we have heart failure clinic now?
All day, every day.
Every day.
Every day.
5 days a week.
5 days a week. We have 3 providers in the clinic every day, 5 days a week. And what we also did was we had a mentality of we want to be in the community and not make patients drive all the way to a faraway place 30, 40 miles from their house to come see a doctor, find a parking garage, and find a different floor, get lost in the big hospital campus. We wanted to keep a patient-centric approach. And so what we did was we expanded to our sister facilities. So we established heart failure clinics in Lake Point and heart failure clinic in McKinney and Frisco and Denton and Grapevine. And the goal was we will be where the patients are. And so we do clinics there at least 1 day a week at those facilities. But then if we cannot find an appointment slot for patients in those facilities, then we always have the backup at Plano where we always have a physician and a nurse practitioner.
Okay. Extraordinary conversation. Before we finish up, let's jump over to research for a second. We talked about the trials. We've got over a dozen trials involved in heart failure. We talked about 3, 4, or 5. How about let's start with a jump ball. You two pick one of them, and let's start with one of them.
Well,
either one of you.
We talked about the cardiogenic shock for a fair amount of time and about devices and temporary support devices. So we are part of the cardiogenic shock working group. We have a very busy shock center. We're one of the largest shock centers in the country based on the AHA registry. So we see about 250 patients a year in cardiogenic shock in the stage C, D, and E shock. And so we're part of the shock working group, which is a trial-based idea of getting data for patients, coming up with ideas of how we can improve care. There is about 50 something centers in that working group. And so that is one of the research studies that we're part of, and entering almost 2,000 variables from our research coordinators to add to the field of shock work, cardiogenic shock. Tim?
What do you got?
Well, cardiac surgery it's a very safe thing to do. We've made it very safe. This hospital has had a focus on quality from the beginning, and it's been very successful. That said, there are patients that are high risk for cardiac surgery. And it's interesting because the same patients that are high risk for cardiac surgery benefit the most from cardiac surgery if it's done successfully. So we talked earlier about putting in these Impellas in cardiogenic shock. There's currently an ongoing trial looking at putting Impellas in to do high risk cardiac surgery and to try to mitigate the risk. And that's called the IMPACT trial, and we're actively enrolling in that. And we've enrolled actually quite a few patients relative to the whole national trial, and that is something that has the potential to change how we think about doing heart surgery in the country, because you can potentially put in a device and mitigate that early postoperative risk by supporting the patient, but we don't know that, and so that's what the trials aim to evaluate.
I'll say innovation and staying ahead of the curve is central to programmatic growth, and research applies that in true form, right? So that's why we always are looking to be part of any of the innovative trials that are in the market. So for example, for amyloidosis, there is a new CRISPR trial called Magnitude. It's a gene editing trial to decrease the amount of TTR. By editing the TTR gene, you decrease the amount of TTR in your body. And the goal is to have a CV mortality or cardiovascular mortality benefit in patients with amyloidosis. So we're going to be part of that trial in the next month or so. So we try to bring those unique trials to our facility, and so that the patients have options to be part of this research and stay at the cutting edge of innovation.
You know, especially in cardiac disease, I think you've both proven this is the times they are a-changing, and you're trying to keep up with it. This is a place that's extraordinary in being able to do that, and in leading that, I think, you're helping change this in the community. So this was a terrific presentation of what we have for heart failure. I can't thank you both enough. Aasim, thank you for being here. Tim, thank you. That was really well done. We appreciate the time. At the end of this, we'll fix it up so that the audience can get in touch with either one of you, get our questions answered. And, somebody needs to be seen to take care of that as well.
Absolutely.
Thanks for being here, guys.
Thanks for having us.
Thank you for having me.
Views and opinions expressed by Dr. David Brown are his own and do not necessarily reflect the views of the Baylor Scott & White The Heart Hospital or any of its officials. The views expressed by guests are their own, and their appearance on the program does not imply an endorsement of any of them or any entity they represent. The information provided herein is considered educational and should not be used during any medical emergency or for the diagnosis or treatment of any medical condition. A licensed medical professional should be consulted for diagnosis and treatment of any and all medical conditions. Call 911 for all medical emergencies.